This is a very common scenario. Anyone who is a clinical cardiologist is practicing in his hospital, comes across a patient comes to the emergency medical services with a severe chest pain with marked ST elevations. And I think if you are an interventional cardiologist and an aggressive interventional cardiologist, what you do, you take the patient to the cath lab, perform the coronary angiography, put in a stent and do what we call as a primary angioplasty to myocardial patient with myocardial infarction. Now in the course of few slides, I want to show you that is it that we are giving the right treatment to our patients, knowing the literature and the data which is available to us in last so many years. Now let's look at first of all, what is the incidence of acute myocardial infarction? It is estimated there are about 120 ST elevation myocardial infarctions per 100,000 population. Globally, there are 3 million annually occurring. USA, it is estimated 1 million deaths annually. USA, every 40 seconds, one heart attack. And though India, there's not much of accurate data available, but what has been estimated that there are about close to 300,000 annual STEMIs occurring in the patients who report chest pain. They have been recorded, but these are all extrapolated data. We don't have no actual data which is available in the Western literature. Now, if you see the data which is available by CREATE registry, which was published from India, about 300,000 patients who had STEMI, 120 per 100,000 population. I have calculated the patients in Mumbai. There are 70 STEMIs occurring per day. And I have tried to see whether we can provide them the treatment which should be an appropriate treatment to handle these patients. Now there's a very simple diagram which has been seen time and again in the literature that for every 30 minutes delay from the onset of symptoms to primary PCI, there's an 8% increase in the relative risk of 1-year mortality. And it's very encouraging to see, and I think we have to implement what has been learned from the trial called the Dynami 2 trial. Currently, the 16 years data is available, and it has shown that the patients who received fibrinolysis versus the patients who were treated with PCI, there is no question, even at the end of 16 years, patients with PCI had a lower risk of death, myocardial infarction, and rehospitalization, indicating that the golden treatment for a patient with STEMI is nothing but PCI, and I think that's what one should try to aim and achieve. And that's why, if you see the ACC, AHA, and even the European guidelines, if you see patients with STEMI, with ischemic symptoms for less than 12 hours, PCI should be performed to improve survival. It has been given 1A indication. I think that's one thing which is a gold standard we should keep in mind, and that's what I'm going to say, that it is possible to do this, and how I have been able to do in my own area, and I think that's what, if you people can implement, that will save a lot of lives. However, in India, there are so many roadblocks, financial constraints. 50 crore people are at the poverty or below poverty level. There's an indiscriminate distribution of cath labs. There's a lack of standardized protocols. There's a different payment gateways, different qualities of hospitals and nursing homes. But I feel the most important is the lack of education and public awareness. This is what I want to show you a couple of cases, that this totally because of the lack of public awareness, that sending a patient or getting a STEMI PCI done as a primary PCI it saves so many lives. Now, there's been a lot of effort done by the STEMI India. There are national registries, CREATE registry, Kerala registry, Oasis 2, DMAT, Northeast, HP registry, and STEMI India. I think then a monumental work has been done to tackle the problem of STEMI and how to treat them, how to bring them into the proper network. And the STEMI India even suggested, all of you are aware, the hub and spoke pattern. But I feel that hub and spoke pattern may be relevant in the context of the entire India. But if you go back into your own community, you can make your own protocol and see how you can make your patient reachable to the cath lab to perform a PCI. And there has been a data also collected that what is the mean time of delay, and it has varied anywhere from 4.5 to 13 hours when the patient reaches. Now, after the last few years of data that has been collected by our NIC registry, what you find that the primary PCI, look at it 2019 and 2021, there has been no difference. It's only 18% of the total PCIs which have been performed. 18% constitute the PCIs for STEMI. So there has been no substantial increase in the number of PCIs for the patients who have STEMI. So indicating that though the total numbers of PCIs are increasing in the country, the percentage of patients for the STEMI PCI is not increasing. Therefore, I think we are really not really looking at how to optimize our treatment for patients with the STEMI. And for that, I went back and looked into the data from the city of Mumbai and divided them into our private hospital where I work. And I found that our patients in 21, it's a very small hospital, 180 bedded hospital. There were 63 cases out of 303 cases who received primary PCI. In 2022, until now, 70 out of 360 received PCI, indicating about 25% of the patients did receive PCI. But our protocol is if a patient comes to our emergency medical services, he must receive PAMI. That's no question. There are no questions asked. There's no fibrinolysis given to these patients. So how do we do it? I want to show you how we do it. Then I compared with the public hospital, a very large public hospital, not only for Bombay, but the whole India. And what you can see, the PAMI is performed only in 5 patients in 21, 2 patients in the 2022, indicating that the facilities and the access to the cath lab, though there, but the patients are being not offered the ideal treatment for PCI. So I learned from a trial called, as I said, STEMI. I looked at the map of South Mumbai. And if you see the map of South Mumbai, more or less looks like that of Denmark. And this is how Denmark looked. There were only 5 PCI centers. In my South Mumbai, we have 5 or 6 private hospitals. And in these hospitals, the first goal is to perform a PAMI in the patients who report at the emergency medical services. So my strategies to provide primary PCI is like this, that every district, city and district is different demographically, economically, education and knowledge-wise. Every area must therefore set a goal of primary PCI as the only treatment. I think it is only we agree, we convince our mind that the only treatment that is appropriate for a patient with STEMI, and there is no other treatment available for a patient with STEMI, is primary PCI. Then only we will start putting our efforts into providing primary PCI and collecting the data, collecting the information, educating the patients, gathering your colleagues in your own area, setting up certain protocols to see that no patient receives a thrombolysis. Ultimately, what you are doing, you are giving thrombolysis, a cheaper one, streptokinase, which costs 2,000 rupees or so, but the recanalization rates are only 25 to 30%. So you are giving a very inferior treatment. So therefore, any other form of treatment apart from primary PCI is inferior. I'll give you an example of my South Mumbai. So for example, here's a patient who was 72 years old, came with a myocardial infarction, left bundle branch block. Now he comes from an affluent area of South Mumbai, but he comes after 24 hours, comes with a left bundle branch block and an anterior wall infarction, comes in as an ostial LAD lesion, total occlusion. Within 2 hours after he reaches the hospital, patient is taken to the cath lab, a recanalization is done, and the TIMI 3 flow is achieved in the patient. Now, why would you ask, why did the patient come 24 hours late? Because there's a lack of awareness. There was no dearth of money in this patient. Patient had a chest pain, no dearth of money, comes from South Mumbai. He can afford to buy the treatment, but because we have not given education, awareness to the patient, he thought this was a gas pain or some muscular pain, comes late. As opposed to this, I'll give another example. A patient who is 38 years, he's a household help. He had chest pain. The employer was very well aware of these chest pains. So she puts the patient into her own car, brings in the South Mumbai, same South Mumbai hospital. And within 2 hours time, the patient reaches and we see the patient total occlusion, PAMI is performed. So therefore, if you look at Mumbai area, 60 by 20 kilometers is 1200 kilometers area-wise. There are 160 cath labs in my city, 160. So therefore, there is one lab for every 8 kilometers. We have 300 and 250 trained, qualified interventional cardiologists. They all can perform primary angioplasty. So the fear is, they are novices. Can they perform a primary angioplasty? And this I picked up from Anderson's data or editorial. He says that although all 5 invasive treatment centers in our study were high volume interventional treatment centers, they had limited experience in performing primary angioplasty at the beginning of the study. However, they were all able to adopt the training program and obtain and maintain the necessary skills. So in my hospital, I have got my entire team 24/7. I can only tell you, I am also available 24/7 even at this age. In the middle of the night, I get a call, I get up, get into the car, call my residents, call my team, all my technicians by rotation, they are available to provide the 24/7 procedure for PAMI. And I think if you put in your mind and said PAMI is the only ideal treatment for the patient with STEMI, I think we'll be saving so many lives. Thank you very much.